Hello, I'm Dr. Kersten, orthopedic surgeon with EmergeOrtho, part of the Blue Ridge region, practicing here in Asheville, Hendersonville, and Western North Carolina. Specialize in orthopedic sports medicine, specifically shoulder and knee surgery. So as a doctor that performs a high volume of shoulder replacement surgery, one common question I get is, what's the difference between a total shoulder replacement or a reverse shoulder replacement? And there are important differences. With a total shoulder replacement, that's more of your traditional match of what our anatomy is. So we have a ball and socket joint normally. With a total shoulder replacement, we're keeping your rotator cuff, we're recovering the arthritic bone on the humeral head with a new ball, and we're resurfacing the socket or the glenoid with a new piece of plastic most often. We're then keeping all the rotator cuff because that implant needs a nice healthy rotator cuff to function the way it's supposed to. With a reverse shoulder replacement, often we're doing these in patients with underlying rotator cuff issues or don't have the same healthy rotator cuff. And so we're actually changing the anatomy around or reversing the anatomy. We're putting the ball on the socket side and the socket on the ball side. From a technical standpoint, what's happening is we're moving the center of rotation of the shoulder. So that center of rotation's getting adjusted a little bit, which allows a different muscle, the deltoid, to take over the function and powering of the implant. In this case, we're putting a metal ball on the socket side, and then we're putting a stem and cup on the humeral side. So again, that orientation is reversed from the normal anatomy. But the incision's the same, the exposure's the same, the go to sleep and wake up procedure is very much the same. So I always encourage my patients and tell them, hey, we've got two good options here for different indications. But sometimes you probably wouldn't know one or the other when you wake up. So the main difference biomechanically with these implants, again, is based on the orientation. With the total shoulder replacement, we're relying on a lot of our own anatomy to keep it stable. So we've got a healthy rotator cuff, which is 4 muscles around the shoulder that hold things in place. So we're replacing the ball with new metal, we're replacing the socket with new plastic, but then the rotator cuff gets repaired back over the top of that. And that implant requires the rotator cuff to function appropriately for it to work the way it should. With a reverse replacement, we're often doing these in patients with rotator cuff disease, so we do not need a healthy rotator cuff. Oftentimes, we're keeping as much of the normal cuff intact as we can, but in this case, we've moved the ball portion over to the socket side, and then the cup goes on the humeral side. This changes the center of rotation of the shoulder, so for some patients, they can notice that subtly their arm's a little closer to the body and maybe a tiny bit longer because that center of rotation has been shifted towards the middle and distal or further away. And that allows then the deltoid muscle, which is the big muscle of the shoulder, to then power the implant and have it provide the motion because we don't have a rotator cuff that does so. So overall, if we look at numbers of these procedures done, it's much less common for an anatomic shoulder to be done. In most patients, or most doctors are probably 20 to 30% of their arthroplasty volume is an anatomic shoulder, and the majority of us are doing a lot higher volume of the reverse. With that said, I still think an anatomic shoulder is a really great option for the right person, but it's a little more narrow indications. We're usually looking at patients with primary osteoarthritis, so they've got healthy rotator cuff, they've got bone-on-bone arthritis with spurring, they don't have a lot of bone loss in their socket, so we do get some patients where they've put this off and they've worn their bone down to an extent where the total shoulder replacement may not be the right option. But for majority of primary shoulder arthritis, we're looking at an anatomic shoulder. For some post-traumatic arthritis, we can consider doing it. It is a better option, I think, for a younger, more active patient because it behaves more like a normal shoulder. So for somebody with some arthritis that's still in the workforce, they're usually going to be happier with their outcomes with a total shoulder than they would with a reverse. For a reverse shoulder replacement, the indications are often rotator cuff tear arthropathy. So that's a fancy way of saying arthritis and bad rotator cuff tears. So we'll get times when a rotator cuff has been torn long enough and retracted, and there's little to no chance of it healing with an arthroscopic surgery or repair. So we'd consider doing the reverse replacement in those patients. Often in folks with rheumatoid arthritis, the reverse shoulder arthroplasty is going to be the better solution for them. It's also a good option for fractures, bad proximal humerus fractures we're often doing the reverse replacement on. And it can also be used in a revision setting, so somebody that's had a failed hemiarthroplasty or anatomic shoulder replacement, it's a good solution for that as well. Functionally, both replacements are very good. I do consider the total shoulder, and if we look at, we can really dive into the data and the outcomes in the research, we do see a little bit better range of motion with an anatomic total shoulder replacement. The majority of patients can reach fully overhead. They have better external rotation and internal rotation, which is more reaching behind the back. They often have a little bit higher strength capacity as well, so we can, they're able to lift a little bit higher weight above shoulder height or do so repetitively. With the reverse replacement, we still get functional range of motion. So patients can reach their hands overhead, they can still reach out to the side, but our internal rotation is often sacrificed. Often we're getting just to a pocket or a belt loop behind the back, but not reaching way up and scratching the back or touching the middle of the back. They're often not able to lift as heavy of weight overhead. So for somebody that's a laborer or still has a higher difficult job, the function with the reverse may not be to their satisfaction. The longevity of these implants is still very good, but it's not as good as what we see in the hip and knee literature. We're often looking at about an 85% 15-year survival rate with a reverse shoulder arthroplasty based on more recent data. There are some total shoulder studies that would suggest that they tend to fail a little bit sooner than the reverse does, but often we still have really well maintained outcomes after 10 years with the total shoulder as well. So one important thing I look at when we're deciding what implant is right for which patient depends a lot on not just the x-rays or the MRI or the imaging, but also their functional exam and their expectations. If somebody's later on in life and their goal is to have pain relief and a more functional shoulder earlier that they can use, and they're not going to have to worry about it as much potentially in 10 or 15 years, then the reverse may be the better option for them. Whereas if somebody's younger and still has higher demands with their job and they come into the surgery with better function and range of motion, they're often going to be happier with the outcomes with the total shoulder replacement than they would with the reverse. So for a lot of shoulder arthroplasties, historically they were done in a hospital setting. Nowadays, with modern techniques and anesthesia and a lot of the surgical planning we do, we're able to cut down on the surgical time, cut down on the surgical risk, and do them even in outpatient settings. The majority of patients, whether they're done in the hospital or in a surgery center, can still go home the same day of their surgery with little pain and little risk long term. So one advantage of doing these in an outpatient setting is we can offer focused teams that just deal with these type of procedures on a more regular basis and do so in a lower cost setting compared to a hospital. The implants themselves are quite expensive, and so any place we can save on other costs is valuable to the patient. So there are some newer modern technologies that we use with shoulder arthroplasty that weren't available 10 or 15 years ago. A lot of patients are familiar with robots from a knee replacement world, and though there are a few robots designed for shoulder arthroplasty, none are really perfected it like we have with knees. Often in my patients, we're doing still a lot of preoperative imaging in the form of a CT scan. So a CT scan is a quick 5-minute radiologic review that looks at the entire anatomy of the scapula and proximal humerus and allows me to map out the entire anatomy of their shoulder joint. This then gets uploaded to computer software that we can then sit separately and plan out the entire operation in advance. So as I'm looking at patients and trying to determine, is the total shoulder going to be a better option or a reverse shoulder option, I can adjust implants, I can adjust sizes, I can do different types on my computer software and have a lot of that planned out in advance. This then translates intraoperatively to things we use to guide the location of the implants and allows me to do these procedures much quicker and safer for patients because we've already thought through a lot of the difficult parts of the case in advance. So one way EmergeOrtho can offer low cost and high quality care is, from a low cost standpoint, we're able to do a lot of these surgeries in different surgery centers. The surgery centers allow a lower cost procedure to be done. So for the patient, that can result in a 30 to 40% savings of what may be billed by their insurance compared to a traditional hospital procedure. We can also contracted with certain insurance carriers to provide some of these replacements at a greatly reduced cost through our bundle programs. From a quality standpoint, a lot of us that are fellowship trained in shoulder replacement in the practice do a very high volume of these, and they've shown clearly in outcomes data across the United States that those of us doing a high volume of shoulder replacements typically have the best outcomes for patients compared to those doing 10 or less in a year. Again, to summarize, we've got the anatomic total shoulder replacement, which is matching your normal anatomy with a ball and socket joint. The reverse replacement, that anatomy is reversed, so we're putting the ball on the socket side and the socket on the ball side. But both are excellent options for patients. So if you've been dealing with severe shoulder pain that's affecting your activities of daily living, if it's waking you up at night and the shots and therapy are no longer giving you the relief that you desire, please seek out one of us shoulder surgeries at EmergeOrtho. We'd be happy to assist you and give you a recommendation as what would be the best option for you.